Let us start this evening, ladies and gentlemen. Today we have a webinar on the biomechanics of incisional hernia repair. And we have Dr. Friedrich Kallinowski from Heidelberg, Germany, who is one of the original researchers on this subject. He's going to be talking to us about the modern concepts of incisional hernia repair biomechanics. What are the factors that impact outcomes? So I will also introduce our co-panelists. We have co-panelist Dr. Hugh McGregor from Australia. We have Dr. Meenakshi Sharma from Gurgaon, Delhi. We have Dr. Pinky Thapar, who is from Mumbai, India. And we have Dr. Sudhir Kalhan, who is from Gangaram Hospital, Delhi, India. So the other speaker is Rodney Jacobs, who is from Australia, and many of you are familiar with Rod because of his complex posts in IHC, as well as he's been a lecturer in our webinar the last couple of weeks. And I will ask Brian, who is the co-moderator in this program, to say a few words. Brian.
Thank you, Ram. Hey, everybody. Good morning from sunny New Jersey and New York. Sorry for any background noise. I'm commuting into the hospital. I'm sure we can all relate. I think it's amazing that we put this together. I'm really looking forward to hearing Friedrich and Rod give their lectures and really diving into some of the nuances of challenges in these incisional hernias that we take for granted. What I would ask is that everyone who logs on who's not speaking, they mute their computers so that there's not a lot of background noise. And I will be here to kind of challenge you. I'm not just going to accept dogma, but I'm really looking forward to this. And Ram, really great job putting it together. Thank you.
Okay then, so without any further ado, I hand the floor over to Friedrich Kallinowski. Please take over, Friedrich.
Okay, should I put on the presentation now?
You could say a few words if you like, and then introduce your work, and then you can start your presentation.
Okay, my name is Friedrich Kallinowski. I'm a senior surgeon back in Heidelberg, Germany. I'm doing surgery now for 30 years, and I sort of have been unhappy with recurrences in incisional hernia repair. We do major surgery and we do have big incisional hernias, and we do not like to have recurrences. So by looking at this, we look at the sort of midline. I don't know, do you see me pointing here?
Yes.
Okay, so we look at the midline incision and the lateral incision, and we look at the abdominal wall as a composite structure made from fascia and musculature. And we repair it with some mesh. It's a textile mesh. It's different from the tissue surrounding it. And so we make out of a composite structure an even more complex compound. And if you look at the words here, shakedown or breakdown, you wonder what this might be. And I think I stopped the presentation for a moment. I don't know whether you can see me on the video. Can you see me on the video?
Exactly,
yes.
That's what I'm saying. But there's no rush.
You see me and you hear me?
Yes.
Okay, so this is a plain sheet of paper, and this is a hernia orifice. You see the hernia orifice?
Yes.
Okay, you see the plain sheet of paper, and it covers the hernia orifice. And now I'm putting some strain on it. And you see how the sheet bends.
Hold it a little higher.
Like this. You see how the sheet bends?
Yes.
And now if you repeat this, you see that it doesn't all come back to its original position, but it starts to walk off my hand. So this is what the difference is between shakedown and breakdown. If a compound starts to fall apart, you have a breakdown, and if it stays, you have a shakedown. And I'm going to explain this in my talk. When people from engineering fields talk about shakedown, they talk about composite structures like a handlebar down here. And this handlebar is tested with repeated impacts. And the same thing with an aeroplane wing over here. And we build a machine doing repeated impacts on hernia repair with tissue. This is Matthias Vollmer. He is from the Hamburg Institute of Biomechanics. And he designed together with us this machine, and a graduate student built it. And we applied the principles to the patients and put them into a registry. So we are going to talk about a bench test and a registry study. Now it should move on, but it doesn't want to move on. Now it moves on. So this is a case we are interested in. It's a 58-year-old man with the 4th recurrence of an incisional hernia after having a liver transplant back in 2012. And he's slightly overweight. He has a risk, according to Todd Hanniford's estimate, of 62%. And they estimate it will cost about $44,000 US to repair him, because he has a high risk and a bad tissue quality. And he had 4 repairs already with all kinds of procedures: an IPOM with a fairly good size mesh, a primary suture with a standard of care fascia closure, an UltraPro online mesh, and he had an underlie big dynamesh Sigat. Since I took it out, I know that the surgeon sort of cut it in half. And then he presented after 1 year with a 19 times 20 centimeter recurrence. And so we did a repair on him. It took us 4 hours, and we took all kinds of procedures, and we put the same mesh in. We put it in an underlined position, and we looked at what we needed to have it biomechanically stable. This is gained resistance to impacts related to pressure. And this is a fairly good figure. And 1.5 years later, he has no pain, no recurrence, and he went back to work after 30 days. So we think this is a fairly good result. And now I'm going to show you the concept. The concept means we take out of the surgical toolkit what we need to make it biomechanically stable. All of these are reviews done by Ferdinand Köckerling in Frontiers of Surgery within the last 2 years. And when we take those procedures as we need them, and we get a good biomechanically stable repair, we do have good results after 1 year. So we published this 2 years ago, and we got some kind of interest. And in your region, there are about 350 people having looked at it, same in the west or east coast of the States. Now, what will I be talking about? I've been giving a short glimpse on the theory. There is a lot of engineering theory behind it, and I'm going to condense it to 5 slides. And I'm giving you some idea about the biology as well. First of all, looking at the abdominal wall, when you condense it, it's anisotropic, which means it's not the same on the sides and in the middle. It's not the same on top with 2 fascial layers. and on the bottom with just one fascial layer. So just keep this in mind, because most models, they regard the abdominal wall as being homogeneous, everywhere the same. And this, I think, is a very basic thing, that this is not the point. The point is that we have to look at some preoperative assessment, intraoperative considerations, and what do we have to take care about with the healing, and then we look at the results. When you look at physics and you build those beautiful structures from steel and concrete, you always have low cyclic loading as a stressor. You look at the compound testing and you have a shakedown, and the shakedown is a tool to define the safety margins. If we look at the biology, we look at cells, fibers, matrix, and mesh. And we have no compound testing. So we see a breakdown in at least 10% of our patients as a recurrence. But we do know once we stabilize the tissues, they will heal. We know it from bone, which is nothing else than calcified soft tissue. Here you see a pseudarthrosis, you put a nail in, you put weight on, and it fuses over time. So if we can get to this basic healing, we will have stable biomechanical repairs lasting for a long time. So what is required to do this? First of all, once you have motion, you do get distension. So if you get pressure on it, like you breathe in or out, or you cough, you get a distension of the belly, and then you get an elongation of the tissues. And this is called Young's modulus, which tells you how much pressure do you have to put in to get a certain dilatation. But at a certain point, you move over into plastic enlargement. So all of these changes will not come back. This is when you, for example, put weight on. If you lose the weight again, you will not regain your original shape. Usually you do not. So when you look at this as a cyclic loading for repeated strain, you will have to look at repeated motions of this. So this is a purely elastic we talked about, and now we look at elastic, plastic, and you come back and it's not all the same, and elastic, plastic, and it moves on and on. So you get elongation as you walk along. Hopefully you will get in a closed cycle or in a sort of elastic shakedown. If you have no shakedown and this motion goes on, you will have a breakdown. Back in the 60s, a Polish physicist already told us in this fancy formula what we need to do to get it to safe limits. It means within time, at a given load, at a given strain and a given elongation, we need to have a pressure-related coming to an end our motion within the volume we are looking at and within the time we are looking at. So this is how the physics work. Now we look at biology. If you look at the cell which is undisturbed, you do have the motors, which is actin. You do have the intermediate filaments, which is cell and cordage, and you have the microtubules and the tubulin for signal and networking. So when you press on the cell, you will have the motors walk up to work against this mechanical compression, and you do have the other structures rearrange themselves. And if you have recovery, that slowly comes back to the original state, but not all the way. It takes a long time. It's like 9/11 in New York. This happens in every point in our body all the time. So what about the fibers? The fibers, they have a load memory. And depending on where they are in their load circle, they can have linear bending, or they couple one to each other, or they have stretching, or they have some non-linear buckling. And this probability for behavior is strain related. Depending on how much strain you had on this is the way they respond, and you cannot predict it. If you look at the things happening on linear bending, you have an energy density between two cells. This is a Petri dish looking at two cells about 1 cell apart. And they have a very dense coupling with the fibers in between. And if the fibers have already buckled and stiffened, the energy between those cells goes down. So the cells react with the fibers to reduce strain. This effect goes around 9 cell layers in all directions. So this means this effect talks to 1.5 millimeters around the original cell being compressed. So for this reason, at this point in time, we cannot model this because we simply do not know how our cells and fibers react. We need to have some kind of machine to look at it. So this is a bench test we built. I told you before, Matthias Vollmer built it, and here you see one impact coming after the others. It's a sharp rise, like a cough, less than 1 second, then it takes about 2 seconds to decay. And as a response, you see the tissue and the mesh moving. So this is the effect we talked about, the cyclic moves we observed before. Here are my disclosures. We do this for 7 years now, and there are a lot of people supported us in doing this. So I think this phenomenon is clear. So what happens now? If we look at those relative motion, it's about 2 to 3 millimeters. And just think about that on an IPOM mesh, the Polish group about Mark Marceniec showed just recently that several centimeters of motion exist just by bending. So this is not really very much what we observe. We see several millimeters, and if those several millimeters continue, the mesh and the tissue will fall apart, but hopefully they have shakedown. So this would be a plastic shakedown. You have some buildup of internal tension, which goes against the retention force of the impact. So this down here is so-called ratcheting shakedown. You see it walks around and it comes closer and closer and closer together, but it never comes to zero. So ratcheting shakedown is something to keep in mind for the healing period. If you have one area somewhere in which you have not reached stable conditions by a plastic shakedown, you are at a risk of having a recurrence at this point. It will be important later when we talk about unstable abdominal walls. So this is just one fiber. It's one piece of mesh being put underneath it. And in between there is some matrix. Sometimes it's better and sometimes it's less. So as you get the impacts, if at one point there is a failure, the whole thing will fail just a few impacts later. If you look at our patients, we counted coughs in them, and 1/3 of our patients cough 424 times and more often per 24 hours. So 2/3 of patients cough less than 424 times. So this is why we took 425 impacts as our test load. And the other thing is, how high will the peak go? There is a work out there by Kopp from the Todd Hanniford group, and he looked at what is the peak pressure, and the peak pressures reached are about 210 millimeters of mercury. So our peak will vary between 200 and 210 millimeters of mercury, 425 times in a single set to say this is a durable reconstruction. But as I said before, if you have ratcheting shakedown, you might still lose your patient's reconstruction because they will slowly walk off. And this will go all the time during the healing process and thereafter, because if you look at freshly formed collagen fibers, and this is a direct microscope look at 2 glass plates with a collagen block in between it, with fluorescent staining. You then shift the upper glass block to the side and you have a strain. So you elongate your collagen fibers because a freshly formed collagen fiber has no retention force. And as it goes back, it doesn't contract, it buckles. But it buckles without getting stiffer. It has just elongated. So you do it again with more strain and it will get further elongated. So in this process, your freshly formed tissue is slowly getting more and more elastic. And if you look at the whole block, let's say of 1 millimeter, these are fibroblasts, these are collagen fibers, there are freshly formed capillaries, and there is a nerve fiber, a C fiber running through it. Then you will see, as you elongate it by 1/3, that the collagen will get stretched, the nerve fibers will signal pain, and the capillaries will ooze. And this is what we see in 3% of our patients if we tell them you can do everything after 6 weeks. If we tell them you can do everything after 8 weeks, we don't see this behavior anymore. So this is why we say in the healing process, patients should refrain from full activity as long as they feel pain. Pain subsides slowly, and pain is a sign of tissue being overstretched if you have a biomechanical stable reconstruction. So if you look at this, this is a piece of tissue and you put a mesh on it. And now you have an impact and your mesh gets bent. And as you see, the bent mesh or the bent tissue both work. They are longer than before. So these two are not really having motions corresponding. You saw it already on the bench test. And what you can do is you put some fixations in. But how many fixations would you need? You need so many fixations that you don't get the effect that a bent mesh or a bent tissue gives slowly way towards the area of better fixation, because then you will have contraction on the other side. And if you have contraction on the other side, the overlap slowly shortens and the defect in the end is open again. And this is what we see on the bench test. So if you look at the result on the bench test, fixation breaks. Here it's stronger, maybe more densely spaced, and the defect gets opened again. So a lot of questions arise now. Do all meshes have this kind of behavior? How many fixations do I have to put in? Can I have any figure to quantify this, to calculate what I need? These kinds of questions can be slowly answered with the bench test. So let's start this. First of all, we had a 5 centimeter defect covered by a 15 centimeter mesh, and we investigated 9 meshes so far, and 7 meshes gave way before the 50th impact or the 100th impact, and 2 meshes hold 425 impacts. So we said these are dynamic intermittent strain class R meshes. They are the good ones, namely Dynamesh Zickert and Medtronic ProGrip. The other ones, they need fixation because they will be not very stable. This one is Physiomesh. We had this result in 2013, and 2 years later, the analysis in the Danish and the Hernia Med Registry showed double the recurrence rate with Physiomesh, so the company took it off the market. So we believe this tells us something about the clinical reality. Now, if we want to quantify it, we go back to Tullo and de Beau's mesh defect area ratio. Sounds complicated. It means that you have a mesh of a given size and a defect of a given size. If both are round, you can skip the pi because it's above and below the denominator. And then you have large R square, which is the mesh radius, versus small r square. Sure, if you have squares, it's one side to the other side versus one side to the other side. And so you can calculate all kinds of coverages and meshes and so on. If you look at what happens, you have a 5 centimeter defect and you cover it with a 5 centimeter overlap. So you have a 15 centimeter round mesh. It's a Dynamesh Sigurd up here. And you see the black squares. It's 100% successful when you repeat the experiments at least 10 times. So now the mesh defect area ratio in this up here, it's 9. Everybody can calculate this. You know, it's 7.5 times 7.5 divided by 2.5 times 2.5, so it's 9. And the other one down here is less overlap, 3.75 centimeters overlap. And then you do have a mesh defect area ratio of 6.25. And you have only 40%, around half of the meshes walk away. And when you reduce the overlap, no mesh holds tight. But when you now close from this circles, black circles down here, you close your opening, you shift the curve up here. So by closing the opening, you shift from a mesh defect area ratio of 4 to somewhere near 9. It's not quite 9. So the difference between this and this is at least 4. So now you have a figure which is a figure without a dimension, which you can use to characterize your mesh and your repair with a dimensionless figure. If you go one step further and you look at the things with all kinds of fixations, here you have different overlaps and you have 4 points of Glubran to glue it, or 8 points of Glubran to glue it, or 8 points of Glubran and 4 sutures, you get all kinds of likelihoods. And you always aim to reach 100% stable conditions, because this is what you want to have in our patients. So here you have Sigurd or ProGrip. The difference is lactic acid grips. So you have the influence of lactic acid grips. And over here you have sutures and tuckers, and you have several combinations of these. And from many of those experiments, if you do 70, 80, 90, you slowly get coefficients from which you can call the additional grip of a measure by adding retention force to the reconstruction. So you say my gained resistance to impacts related to pressure is the mesh defect area ratio times the coefficient for the mesh, times the coefficient for the fixation, times the coefficient for the position in the abdominal wall, like underlay or sublay or intraperitoneal, plus the coefficient for closure of the defect. This is 4, as we said before. The others vary, and I'm going to show you how they vary. These are the influences. Most influential is the tissue distension, because it's varying between 1 and 18. The mesh, it's varying between 1 and 14. Sutures and secure straps or absorber tuck and Glubran, these are fixation measures, differ on the average, but they also differ by the handling of the tucker, for example. You know, when you press the tucker with different newtons, we varied between 20 and 16 Newton by pressing of the tucker, and we varied the angle of pressing the tucker, and this was 20 to 25 variation, 20 to 25% variation in doing so. And so you get this as an average calculation figure, but you must be aware you still should be very careful when you apply things, sort of always doing them for yourself in the same way. These are different orifices. And if you look at 100% likelihoods of repair, you see that they move up with increasing orifice sizes. So if you say around 5, I can bridge an orifice below 5 centimeters, and around 50, I can bridge an orifice of about 10 centimeters in diameter. So if you see this, you see that your grip must go up. And if you take the average of these 100% values, hello?
Yes, we can hear you. Please go ahead.
Okay, I think I lost you somewhere. Or did you hear that the size is influential to the grip durable reconstruction?
Please start from there again. No problem.
Okay, so when you look at these, you have increasing diameters and you have smaller sizes on the left and larger sizes on the right. So these are about 5 centimeters and these are about 10 centimeter hernia diameters. And you see that the grip increases from 5 to 50. So as you take those values and you make an average out of it, you come to this line from 5 to 50 with increasing hernia diameter. So if you look this up, because it's a monthly update, you want to look at hernia today. Unfortunately, it's mostly in German, but you know, this is just in press at the moment, so you might read it at the end of the year. But it's already in February, we published it in our weblog. So you're most welcome to look there. And if you want to do a pre-operative assessment of the critical risk to impacts related to pressure, you know, is the minimum amount of retention force I need for durable reconstruction, you can sort of take from this line the formula 0.5 times hernia size in square centimeters plus 15. So now you can easily calculate what you need to have a durable repair. So if you look at the influence of the tissue, you need to analyze sort of the stress-strain relation of the individual tissues. And we did this with pig's belly and with bovine flank. And you see the pig's belly is much less strain resistant and takes much less stress before it breaks. You can say it's about 1 to 2 between pig's belly and bovine flank. And you do this on a texture analyzer. Here they test some glue, but you can test tissue at the same time. So there is a lot of individual variation in this. Also, you have a distinct average, but you have an individual variation. And this individual variation brings you to the conclusion that you need to analyze the individual sample in the patient before you do the repair.
Friedrich,
Why do you need, sorry?
I'm sorry, may I interrupt you for a moment? Can you
Sure.
just go back to CRIP and tell us how it is different from GRIP? CRIP and GRIP,
Yeah.
yeah. Can you just say that again?
This one means what have I done? Like I did a reconstruction and I put in, let's say, 100 stitches. So I calculated with 100 stitches. This is what I did. I gained a resistance to impacts related to pressure. Okay?
Okay.
So, and this is what do I need as a minimum to have a durable reconstruction. You know, when I be up here, I'm safe. When I'm down here, I'm not safe. This means the word critical. You could say minimal, but then you would have not grip, but grip. And I found grip much better because it's a grip concept, okay?
Yes, yes.
Okay, so now you need to do a lot of experience because each of those points is at least 10 series, because when you look on this one, you see there is some spread. You know, it's not like you have one point like this one and that's it. You need to do it again and again and again. There is a variation of 10% in your experimental results. Okay, but when you have done this 10 times, you will have a spread of these 100% durable repairs, and then you take the median value and you put the line through it and you say, okay, my critical resistance to impact-related pressure on this patient with a 100 square centimeter hernia would be 65. So the minimum here I need to reach is 65, okay? And then I can reach it by a mesh defect area ratio of, let's say, 5. I need to take a piece of hernia mesh which is 5 times larger, and I need to do at least 26 stitches to it, because 26 stitches is 13, and 13 times 5 makes 65. So this would be the absolute minimum I need to do to make it a stable reconstruction. I don't know whether it's clear now how we think in this.
It will take a little time for many people to understand this, but I guess many people may have understood that you need a bigger mesh and you need more fixation.
That's right. That's right. So you can sort of pre-operatively assess what you want to have as long as you have the correct hernia size, because this is the other point. What is my tissue distension and what is my hernia size? And this is the point we are coming to next. Okay?
Yes.
Okay, this again about tissue distension. Though, to make a long story short, if you look at those parallel lines, you see that those behave the same, but they are definitely different in size. This is porcine 7.5 and this is bovine 5 centimeter. And why is this? Because the bovine 5 centimeter dilates up to 7.5. So this is why tissue elasticity is so important. You know, you need to know the tissue elasticity in order to make a durable repair from this test. And how do I get the tissue elasticity of my patient before I operate on him? I can do a CT scan with and without Valsalva's maneuver. So this on the left is a CT scan of a 42-year-old man. He had a repair of a small hole of a liver transplant about 2 centimeters with an IPOM. You would say this is definitely good because it's almost 20 centimeters wide. So it's a good size IPOM for this small hole. But what happened here is that the central fixation here and the left-hand side, they are differently long. So this one is longer than this one. So it's unstable because it's not evenly spaced. And so you have the point that in this area, you have a weakness. And this weakness over 1 year gave way to a 10 centimeter recurrent defect due to the effect of this not ending ratcheting shakedown. Remember? Can anybody hear me?
Yes, yes.
You remember that we said the ratcheting means you have impact and impact and impact and impact, and it does not ever truly come to an end.
Correct.
And you have one point, it can be only 1 millimeter wide. This would be 10 cell layers in distance. This would be enough for the fibers to be dilated in between to a larger and larger and larger and larger and larger reopening. So starting from a 2 centimeter wide defect, The effect was a 10 centimeter recurrence after 1 year. And now we do Valsalvas, and we see that the distance of the defect only enlarges by 10%. The hernia sac enlarges by 50%. So this is what we say Valsalvas can tell you. Valsalvas maneuver can tell you how much do you have to increase the necessary critical resistance, in this case by about 10%, to have a durable repair. So we did this on 105 patients, and there were some patients who had almost no change in diameter, and we had patients who had a 5-fold change in diameter. So this is really a very individual thing. But if you assess it, you have a next tackle to conquer. The good thing first is that you have the hernia size after Valsalvas is the hernia size you measure intraoperatively. This is the good thing. And now the bad thing is that if you have an unstable abdominal wall, you need to assess this several times to have a very small error. So you have to assess it about 12 times before you have an error below 1%. So this takes about 3 hours of evaluation. We do this at the moment, but we want to get rid of it. And how can we get rid of those 3 hours of manpower? We can get rid of it by having an analysis with computer algorithm. This on the left, it's artificial intelligence telling you the hernia area. It's by Philip Lösel. And this is a non-rigid B-spline registration telling you the unstable abdominal wall by Samuel Voss. And how do you bring those two together? You bring those two together when you look at the shift of the tissues. Here you see the shift of the tissues during Valsalvas. And when you look at the shift of the tissues, depending on whether you look at 20 millimeters or 25 millimeters or 30 millimeters or 35 millimeters, the area of the unstable wall comes down to the hernia diameter. So if you take a shift, or you require a shift of 3 centimeters in this case, you will have identical results. But in this area, this is the area of weakness due to ratcheting shakedown. So this is the area which you need to cover as well. So this is an L-shaped incision, a transverse and a median incision. And here you do have, at this point in time, very little shifting of tissue and no hernia opening yet, but you do have the weakness giving way to ratcheting shakedown. So you need to cover this. And when you want to combine those two procedures, you need to have something which is an algorithm taking itself. So this is what the algorithm does. It takes all the slices and it puts out the hernia diameter and the unstable abdominal wall on a surface created torso. So this is the hernia diameter, and the unstable abdominal wall would be surrounding it, the white area. So at this point in time, it takes about 6 hours to calculate it on our university main calculator, and we want to bring it down to 15 minutes and make it a bedside available, and then it will be good for everybody. At the moment, you need to take your CT scans, evaluate them, and do this at least 12 times if you have an unstable abdominal wall. Now we come to the patients being put in the registry. The patients repaired by this approach. This is called Stronghold, and it's part of Hernia Med. Hernia Med is the major German registry made available by Ferdinand Köckerling, the same person who already did all the reviews we showed beforehand. And Stronghold was financed by Markus Büchler, my boss in Heidelberg, a world famous surgeon. And we put all the patients in here. These are the 10 hospitals putting patients in. This is the major hospital of the German army because they joined the group. This is ourselves. These are associated hospitals. Here my wife works, Regine Nessel. She is a female consultant surgeon in a major community hospital. And over here you see the points we put in. The hernia opening, the type, shape and size of the mesh, the minimal overlap, the number and kind of fixation points, the closure of the peritoneum, and then the surgeon can change the coefficients for position fixation of the mesh defect area ratio, and then the algorithm calculates grip. He can, but he doesn't have to. You know, the machine calculates those coefficients from those input already. So he then gets the grip, and then we look at the patients after 30 days, 1 and 6 months and 1 year. First, in hospital results, we have a rate of 3% with a SEDA risk for wound healing between 12 and 46%. It's 413 patients coming in. They are mostly overweight, as German patients are. They have risk factors. About 1/4 is recurrent. It's a decent size incisional hernia and a decent size mesh. We put in all kinds of different surgical techniques, and the average stay in hospital is 6 days, which is for Germany the medium in-hospital stay of all incisional hernias. So the patients do not really stay longer. Surgery takes a little longer due to the size. You need to prepare for the mesh to be put in, but at the point, this is what it is. And the 4 hospitals I'm actually directly being attached to, we have an average grip value of 191, which is 3 times of what we just calculated for a 10 centimeter hernia. And we have 164 patients in our observance, and we have about 90 at the moment after 1 year. And just one person, he takes metamizole as a painkiller, he says, which is a free drug for us. And we have 3 patients noticing the incisional hernia at all after 2 hours of doing shopping. So these are our results. We have no recurrence at the moment. So that's the talk. Thanks for listening. This is my phone number, and this is the website if you want to look it up. And if you have a patient who you think could need this, he could contact the hospital or the international office. And anyway, this is a look from Heidelberg Castle over to where the university is. So you see there's a bright, shiny light. Thanks for listening.
Thank you very much, Friedrich. You can unshare your screen now. So that was probably the most nerdy talk any surgeon would have heard, especially in the field of hernia surgery. We typically talk in terms of operative findings, post-op complications, and yeah, to some extent, data in terms of recurrences and percentages and all that. But this was digging deep into the subject. Now, we have another speaker waiting, Rod Jacobs from Australia, but I'm going to keep Rod waiting for another 5 minutes. And I want to pick your brains for the benefit of the larger audience, because I'm pretty sure a fair number of our audience, both in this platform as well as in our large Facebook group, would not have understood a fair bit of what you consider to be very, very basic stuff when you deal with the biomechanics aspects of mesh repair. So let's just have a short question and answer session. Please keep your answers short so that we can keep moving and give people an idea which they can grasp. So essentially, looking at the biomechanics, you have checked the behavior of mesh and the tissue when it is subjected to repetitive stress, and you have subjected the mesh on a pig belly, and you've taken it to the highest pressures possible for around 425 times a day, which is the number of times a patient with a cough can actually cough in a day. And then you have studied the behavior of these meshes and made all your calculations. Correct so far?
This is a very good description, yes.
Yes, that's my job. All right. So now you have found that there are certain things which matter in how well a mesh integrates and gives a durable repair. And one of the most important things is that you must close the defect. If you don't close the defect, the chance of the mesh eventrating out is higher. Correct?
It's a question of debate at the moment. We are investigating closure of the defect, and it's not generally true that the bridged repair cannot be biomechanically as stable, especially if you use the double flap technique proposed by Tullow and de Bow, or Pedersen, Montgomery and Pedersen just recently. These are publications of March and May last year. So it's published just recently, and it's probably as good as closing a defect under tension.
Right. Now that is an extraperitoneal approach, a retromuscular approach to abdominal wall reconstruction. And your tests were largely on intraperitoneal onlay mesh, underlay category. Am I correct? Your bench tests
No,
were...
95% of our tests are running on a retromuscular extraperitoneal repair.
Okay.
So we are talking about what does the position do, and the position intraperitoneal using for experimental purposes the same mesh reduces the durability by 10%. So most of it is extraperitoneal repairs.
Right. Okay. So we may need to close the defect or not is something you are not committing right now, but by and large, the surgical community as such has taken it to heart that we must close most defects, if not all, except the tiny ones, because there's plenty of clinical evidence to that end. Now, the second thing, the mesh must be at least 4 times as wide as the defect. If the mesh, if the defect is bigger, it may not be 4 times, but it may actually be 5 times or 6 times. Is this correct?
The mesh defect area ratio can be counterbalanced by more fixation. And you must put the fixation in the areas of proposed instability, as you have seen on the CT scan with Valsalva beforehand. And be aware that closure of the defect is hard for large defects. If you have a defect 20 by 20 times, it's very hard to close it. Then it's much better to use the double flap technique.
Okay, so that is a very, very interesting thing. So that would kind of give credence to the Edinburgh School, Andrew DeBow and Bruce Tallow. They have been talking about this for a number of years, and they have published a few papers on this. The other thing is the fixation. So you're saying that in order for the mesh tissue interface to be stable, you need to fix it much more. So how much you fix depends on whether you're using transfacial sutures, whether you're using Glubran, or whether you're using absorbable tacks or metal tacks, right or wrong?
This is right. They all have different retention forces, but please be aware that transfixing sutures do cause pain due to a pointed, a pointed pulling on those transfascial fixations. So it might be better to have a running, smaller, just lying it on the mesh and then make more points to it.
All right. Now, this is an interesting point that by and large, those of us doing retromuscular repairs for large hernias have more or less done away with penetrating fixation. So we don't fix those meshes anymore because we believe that the mesh is now sandwiched between the posterior rectus sheath and peritoneum below, the entire abdominal wall anteriorly as well as laterally, and the intra-abdominal pressure sandwiches it together, and it becomes, it cannot move because it's a very large prosthesis. The defect is closed. And even if you do a peritoneal flap, the mesh still is sandwiched by the intra-abdominal pressure, so it does not move. And if it does, it probably is not significant because the mesh overlap is probably at least 10 centimeters on each side. Comments?
Well, this would be an interesting question to ask with titan stained meshes, which you can see on MR, for example, because biomechanically, if you put two foils together without some sticky things in between, they can still walk away. I mean, why should tissue and the mesh interface be so strong as not to walk away and not crumble in one edge in unlucky conditions, So I think we should wait until we see the results on those titanized meshes.
Right, but titanized meshes prevent adhesions as well, right?
For the adhesions to form, you need to have stable conditions. If you have constant pulling, you will have an edge where you will build out a new hernia sac, as you saw on this unhappy chap with this fairly small hole, but the instability on one side, and then he got this large 10 centimeter recurrence after 1 year. So you are right, mechanically it makes sense to say it's a sandwich, but biomechanically, you should be aware that you have registering shakedown and elastic tissue not healing and bringing strength under uncertain conditions.
Now, your point about the histologic evidence showing the movement of the fibers, collagen fibers, away when subjected to strain in the early post-operative period. And you're saying that from 8 weeks onwards, you have a period of stability. So does that mean that the old time, and most people here may not even know what I'm talking about, in the last century, when I was a surgical student, our bosses used to mandate 3 months of bed rest after a ventral hernia surgery, even after an inguinal hernia surgery for that matter. No weightlifting, not much movement, stay in bed. So are you suggesting that that kind of ancient practice of subjecting the patient to rest, strict rest, is going to help the mesh integrate better?
No, my point is that you should have a biomechanically durable condition in the first hand, and then be sure not to overstretch it, So if we would want to develop something in the future, we would have to have a sensing device on the abdomen to measure what stretching we do during a certain exercise. Until this, I would recommend a durable repair, 8 weeks of letting it heal in, and then patients go back to work and can do everything, you know, and we had no recurrence so far. So
no, but I have a problem here. When the patient is not doing any abnormal activities, but still defecating, coughing, and sneezing, he is subjecting the repair to the highest levels of stress. So how does lifting a few kilos of weight, whether he's lifting a suitcase and putting it overhead in the airplane, or whether he's actually going to the gym and doing some movement, loaded movements, how does that change? Because evidence has shown that the highest intra-abdominal pressures occur in coughing and sneezing, and you probably know it better than anybody else.
I would agree with you. And if he can do this without pain, he can probably do it. But if he feels pain, he should probably refrain from it. So pain, I think, is a good danger point.
Right. Okay. So it's a very interesting subject, and I'm sure you're going to come out with more information for us down the line. The last question before we move on to Rod, you were talking about the CRIP, which is the critical level below which you're going to have higher chance of disruption, a breakdown, so to speak. And most people would like to know, what does it do for me? What am I supposed to do as a surgeon? How do I estimate the critical level below which I don't want to go? I want to stay above that critical level, and I want to ensure a good repair. So should I choose certain meshes which you have tested, for example? Second is, should I specifically look at the defects and the size of the mesh go above the 13:1 mesh defect area ratio? And should I fix it X number of times? How exactly is a clinician, a surgeon, how is he supposed to use your research to his own practice?
I think all 3 points you raised are helpful in reaching a stable repair. You know, you should have a good mesh. You should have a fair idea about the size of your hernia, the distension of the tissue under load. And when you have those two, you then can calculate your necessities of fixation points or flat gluing or something like this to make a durable repair. All 3 points you raised are very helpful.
All right. Thank you very much. So
I think one last question.
Yes, right.
Frederick, really nice presentation.
I would
second to last. It's Brian Jacob from New York. I would not have used the word nerdy. I thought it was fantastic. And the truth is, not enough surgeons are educated enough about this science to even have a clue that all this exists. It's a big problem in the States. I would say that 90% of the surgeons in the States do not have a clue about this science. Worse, I think 95% of them don't seem to think it matters. And I absolutely think it does. But in all of your studies with humans, how do you take into account the variable of technique? It's well known that all surgeons are different. Some people have one way of doing something, some people have another, but you know, and if you watch videos of people operate, you'll see the difference in technique. So how do you account for the difference in technique when you look at healing and recurrence rates?
You know, in our group of 10 hospitals, we have 20 different surgeons, and we agreed on 8 points. If we observe those 8 points, we sort of seem to be getting the same type of results, which means no pain, no recurrence, or low pain and little recurrence in the long run. So it's like when you build a bridge, you know, every steel worker, he has another way of doing it. But when he makes a nut and a bolt, he has a key telling him how hard he must push and pull. And this is what we need to develop to get over those individual problems in the long run. But at this point in time, if you have an interested surgeon, and I think most of the surgeons are interested in it, and you train them like one day, they usually understand those 8 points and can apply them in their daily practice. So if you take a senior consultant one day, you talk about things as we did now for an hour or so, you probably get good results. This is my experience. So I think you don't need to have all that fancy science. I just thought I'd tell you something about it to see there is more behind it than just screwing or tacking. And I think in the long run, better training will be a good trick to do it.
For sure. In the inguinal world, we've come up with what we call the critical view of the myopectinal orifice. And we've kind of written about this in the International Hernia Collaboration. We published about it. It's sort of the view you must have before you put your mesh in. Perhaps a good way to teach your 8 points would be to give it a name and be like, look, you haven't really done a hernia unless these 8 points are done. This is sort of becomes the critical points of the ventral hernia repair. And it's sort of like the safety view so that we can sort of start to standardize the techniques. I love your answer.
Well, my answer is if you follow the grip concept, you know, you need to have a good grip for a durable repair, and then you have 8 points to follow, which is not too much. I think that can be done.
Great. Thanks again.
You're welcome.
All right. So we'll come back to you, Friedrich. Please hang on and maybe get yourself a glass of wine or something. It's probably a little too early, right? Okay. So Rod, are you ready? Okay. So Rod, please go ahead. You need to give Rod privileges.
Should I do something? Or?
You need to share your screen unless you just want us to look at your face.
Oh, I see. How can I share it? Ah, here. Okay. Gone. Is this what I needed to do?
I'm sorry?
Did you lose me now?
Yes, yes. I wasn't talking to you, Friedrich. I was talking to Rod, actually.
Oh, okay.
I'm sorry.
Sorry.
I didn't mean for you to do anything, actually. I'll then get that glass of wine.
So
Yes, Rod?
I'm trying to share my screen. Is it not coming through?
No. Ehem, are you there?
Yeah, the settings for sharing screen are on to all participants.
Yeah. So please share your screen, Rod.
Yeah.
Yeah, that's it. Good. Good to go.
So good evening to everyone in India, and good afternoon in Germany, and good morning, Brian, in New York. So I've just thought I'd be controversial and say should defect should be mandatory after having listened to Dr. Kallinowski. I could just stop here and say yes, but we'll go on and do a bit more. So I'm not moving forward, unfortunately. So as Graham said, I'm from Melbourne, and he promised cutting edge from the labs, but given that it's been more than 3 decades since I've been in any lab and we've had Dr. Kallinowski, I must be giving a view from the trenches. And so these are the disclosures which will become relevant later on, as you'll see. So in terms of modern ventral hernia repair, we're trying to get an operation that cures the problem. It doesn't have high complication rate. It has a low recurrence. It has a low cost to the community, and hopefully it'll be both cosmetic and produce a functional and dynamic abdominal wall. And as you can see, all these 3 people have a functional abdominal wall. So abdominal muscles, they, as we know, act in concert. They form a girdle. They have a number of functions. So they protect, they stabilize, they move, and of course they help in respiration when necessary. And I suppose we can add balancing a beer between mouthfuls as well, given the previous picture. And these are the various muscles, and their vectors work in differing directions. As you can see, the obliques retract away, as does the transversus abdominis, and the rectus muscles obviously help flex. And they work through the linear alba, which acts like a tendon to coordinate the muscles. And so if you remove the linear alba, or you damage it and you produce a hernia, then you get a number of problems. You get the muscles retract, they atrophy, they fibrose, their compliance goes, and you get this condition called myopathic disuse atrophy. So midline closure, is it necessary in ventral hernia repair? Well, apart from improving cosmesis, as we've already heard, it gives us a greater ability to put in larger pieces of mesh. It should improve abdominal wall function, given that the central tendon is the most important part of that, and it should give us a better quality of life. But does it have clinical importance as well in terms of recurrence and surgical site problems? And at the very least, without a closure of the midline defect, you're going to get a bridge repair, which could result in eventration and so-called pseudo-recurrence. It has a number of other downsides as well, as we'll see. And so here from the European Hernia Society Principles of Ventral Hernia Repair, the number one thing is primary closure of the fascia under physiologic tension. Now, whatever that physiologic tension means, I'm not certain. So midline closure, should it be mandatory? Well, as you can see from my background, I tend to abreact when I hear things are supposed to be compulsory, unless someone can give me a good reason for it, or unless I can find the evidence myself. And so this is from the Ventral Hernia Working Group, published in 2010. And there it is, number 2, to centralise and reapproximate the rectus muscles. And it was strongly recommended, but the level of evidence was actually quite low. And so what evidence is there that defect closure has better outcomes, and that there aren't negatives in terms of having to do more complex surgery or riskier complications? So firstly, there are in fact some experimental studies which show that an incisional hernia causes atrophy of those oblique muscles, and that if you put them back together again, it restores the muscle bulk. And indeed, there are some human studies that show restoration of the midline, either through a component separation, anterior or posterior. It results in hypertrophy, in particular of the rectus muscles, but also of the obliques. And you don't see that if you just have a bridged laparoscopic ventral hernia repair. Additionally, there's some data about function. This is largely from a group of Danish surgeons that show that you increase the maximum torque you can generate when you put the midline together, and that occurs whether or not it's reinforced with mesh. It's less than normal, but it's still more than you get if you have a bridge repair. More recently, in fact, Valentin Opera, speaking at the European Hernia Society virtual meeting just a few weeks ago, showed in fact there's a linear relationship between the width of the defect and the loss of function, and that in fact that function could be improved and held out to 12 months after abdominal wall reconstruction. And it not only improves the abdominal muscles, but it also increases the strength of back muscles as well. So we know certainly that there's evidence that it increases muscle mass and that it improves function. But what about clinical outcomes? Is there any evidence for that? Well, actually, there's not a lot of evidence from open repairs. This is one study done by a number of surgeons from Dresden, and they had 175 consecutive hernias that they tried to put together, but in 50 of those, they were unable to close the fascia, having done basically a retrorectus repair. And so in that 50, they put an inlay in 31, and they left the remaining 19 bridged. And they found that their infection rates and their recurrence rates were much higher in the bridged group, and that fascial closure significantly reduced both infections, and they got fewer recurrences. This is a study from the MD Anderson in Texas. It's the same roughly group of 200 patients studied over a number of years that were put together with acellular dermal matrix. And as you can see, that the complication rates, the wound occurrence rates and the recurrent hernia rate were all significantly less in patients where they were able to get the defects together. They published a number of cases over the years and showed that the odds of getting a recurrence were 7 times higher if you didn't close the defect. Overall complications were higher. Wound complications were 14 times higher for when they bridged. Now, that's not unsurprising when you're using a biologic mesh, of course, but the fact that they didn't see that when they put the midline together, I think is the important thing. And in fact, in their last paper, they felt that midline closure was protective against recurrence. So that's in open ventral hernia repairs. What about laparoscopic or minimally invasive hernia? So we've had an evolution really in laparoscopic ventral hernia repair from the original descriptions from LeBomp and Booth, where we basically had an IPOM with a bridged repair. And over the years, it's gone from 3 centimetre overlap to 5 centimetre overlap. And then Kilala and then the late Morris Franklin both described closure of the defect. And that's become a more popular method of doing IPOMs anyway, so-called IPOM plus. And there are a variety of ways of doing it that have been described over the years. So you can see here a number of pictures, some of which are straightforward. The straightforward patch, suturing it, tacking it with various sorts of tackings, transcutaneous closure of the defect with sutures, and the very elaborate system published by Sean Orenstein, which had shoelacing and transfascial sutures and tacks and more transfascial suturing. And of course, these days we've got a number of ways of closing it. We've got continuous or interrupted sutures. We've got permeable or absorbent sutures, unidirectional barb sutures. It can be, the sutures can be put in either extracorporeally or intracorporeally. There's lots of ways of doing it. And because of the results of intra-abdominal meshes with problems, there's been a move to try to keep the mesh out of the abdominal cavity. There are a number of other techniques for minimally invasive repairing ventral hernias, but these all mostly also facilitate fascial closure or putting the rectus together. So the first systematic study looking at various primary fascial closure versus bridging repairs was published by Nguyen, and they found no statistical difference in either occurrence or seroma formation, but the patients seemed to be more satisfied if the defect was closed, and there was certainly less bulging, but they realised that the data was pretty poor. Nevertheless, the International Endohernia Society suggested that reconstruction of the linea alba improves functionality, and as well as a number of other things. The level of evidence was level 3. It was a grade C. It was a grade C recommendation. However, SAGES, a couple of years later, thought that there wasn't sufficient evidence to warrant closing the abdominal wall, and they would leave it up to the surgeon's discretion. So we have 2 different guidelines available in the middle of this 2010s. So is necessary closure? Maybe, maybe not. These are 2 articles published in 2016 at roughly the same time, one in the British Journal of Surgery and one in Surgical Endoscopy. So this is from Tandon, and this was the first meta-analysis of a number of previous studies. And they came down on the side of saying that adverse events, which they described as either recurrence, pseudo-recurrence, eventration or bulging, was significantly lower when the defect was closed. And as you can see, that most of the patients in those studies had defect closure. Both seroma rates were reduced, as was length of stay. So then Kalala, in 2016, he published perhaps the definitive early work on midline closure, 1,300 consecutive cases with significantly wide defects, many more than 10 centimetres, with what we would consider the standard of care at the time, using an IPOM with tacks and transfascial sutures, and both intra and extracorporeal closure of the defect. And he had less pain, bulge, seroma, and a recurrence rate of around 4%. Now, in contradistinction, this was an article that was published in Surgical Endoscopy. It was a multi-institutional study from the United States. They originally had nearly 16 or 1,700 patients that they whittled down to just under 200. And their findings were that there was no difference between either a primary fascial closure or bridge repair. But I think there are some interesting aspects about this study that are worth looking at in a bit more detail. If you look at their recurrence rate and their wound infection rate, it's substantially higher than those reported in similar studies, either at the time or subsequently. So you can see that those on the right-hand side there, the wound infection rates are of the order of 1 to 2%, with recurrence rates less than 6%, and yet their SSIs were of more than 20% and recurrence rates of around the same. So I'm not quite certain about the data there, and perhaps Brian might even be able to explain what went on. And in fact, if you look at this is from the forest plot from the Tandon article, it shows that that article by Weningren is the outlier by some way. This is a further study published in 2017. And although this study didn't show much difference in the way of seromas, what I find interesting is that 2/3 of the patients had a primary fascial closure despite the SAGE's guidelines. This is an article published this year, which again shows reduced seroma rates, decreased recurrent rates, and similar pain when the midline defect is closed. This article, which first appeared online last year and has been published in Annals of Surgery this year, again shows an improvement in quality of life, similar pain, but doesn't show much in the way of a difference between wound events. Yuri Novitsky, who I'm certain you're all aware of, their group published in 2018, again about 780 odd patients, of which about 1/3 had fascial closure. And again, in the typical way we would do it, the transcutaneous closure of the defect, the knots tied after the desufflation of the abdomen, good overlap with a coated mesh, transfascial sutures, and a follow-up at 12 months, which showed less seromas, less wound complications overall, and a lower recurrence rate. And finally, this is a real-time data from surgeons in everyday practice. This is an article that was published by Baker. These are Danish surgeons, and this is from the Danish Hernia Registry. And when the defect was closed, you find here that the recurrence rate was substantially less. So this is the bottom graph here. So defect closure in real life by real life surgeons reduces the recurrence rate. So I think we can say that midline closure certainly reduces seromas and probably wound complications overall, as well as wound infections. Certainly diminishes pseudo-recurrence and real recurrence, and it seems to do so without increased pain, and it probably increases quality of life. So, as we've already seen, one of the things in ventral hernia repair, especially laparoscopic ventral hernia repair, recurrence rates is related to defect size. We know that the bigger the defect and the smaller the overlap, the more likely we are to get a recurrence. Elegantly shown by a Carla-Blank's meta-analysis in 2016, where the incidence of recurrence dramatically increased as you increase the amount of overlap. So this is actually from Philip Myson's article on the with or without transfascial suture trial, but it elegantly shows that if you do a double crown fixation and you close the defect, you have a much larger interaction between your mesh and your wall, and you probably get a greater area of stability. And it disrupts the forces that would be causing disruption, they're more evenly dispersed throughout the mesh, and it's less likely to migrate and move. So one of the other things that we've already touched on in Professor Kallinowski's talk was this concept of the mesh defect area ratio, first touted by Bruce Tuller and Andrew DeBow. There was an article by Horters published in 2017. In fact, it showed that when the mesh defect ratio was greater than 13 to 16, the recurrence rate was significantly less. And if you combine that with an overlap of more than 5 centimetres, the recurrence rate was virtually 0. This was for straightforward IPOM. This is without closing the defect. But one of the things it does show is that if you've got, for example, a 5 centimetre mesh, 5 centimetre defect, then you need a mesh that's 18 to 20 centimetres in diameter if you're just going to do an IPOM. And that's sometimes technically difficult to do and get the fixation correct and get the mesh to sit flat. And so clearly, if you can close the defect down, you can put in more reasonably sized meshes that can be better embedded down if you're going to do a intraperitoneal mesh repair. What about optimal fixation? We've already touched a bit on this, but there doesn't seem to be great benefit for one technique over another. The most recent studies do suggest that you need transfascial sutures and permanent tacks. But as we've just heard, the need for fixation clearly depends upon the size of the defect, the mesh, the type of fixation, and the patient's abdominal wall characteristics. So midline closure seems to be a good thing. It does all these great things, reduces recurrence rate, increases your muscle mass, probably improves your function and quality of life. And so the updated guidelines from the International Hernia Society have now given us level 2 evidence and a grade B recommendation that restoration of the linear elbow should be attempted. So what if you can't get the midline closed though? So you need to either increase your abdominal capacity or decrease the abdominal content. And there are various ways of doing both of those, as we're all aware of. So preoperatively, the use of Botox to produce chemical relaxation, or intraoperatively, some form of component separation and myofascial advancement may be necessary to get the midline closed without the tension that we're talking about. So it's more likely to be necessary if you've got loss of domain or a wide defect, or as we've seen, if you've got reduced abdominal wall compliance. Now, some of these can be dealt with by giving Botox beforehand. So it's possible to predict clinically where you're likely to need some sort of myofascial advancement, but it's also able to be used in a semi-quantitative adjuncts using CT scans to either use the Carbonell rule, where the width of the rectus or combined width of the rectus should be more than twice that of the defect, or you can use the component separation index, which is a CT guided angle, and the wider that angle, the less there is likelihood of being able to get the defect together without tension. So in summary then, the defect closure, I think it's certainly a benefit in ventral hernia repair in both open and minimally invasive surgery. There's fewer wound issues, fewer occurrences, probably less pain and better function. It's a good thing. Might require myofascial advancement, and therefore it might require advanced minimally invasive techniques and skills, or the use of a robot. So if not mandatory, I think it's highly recommended. Perhaps it should be routine when necessary, and we can debate when necessary is in the questions coming up. So a routine procedure, as the man says, if you're used to being operated on. Thanks, Ramana.
All right, thank you. Lots of important data in your talk, Rod. And of course, sneak peek into your six-pack abs is priceless. Before we move on to our panelists, and I'll let Brian talk for a bit. I just have one question. for Friedrich. Friedrich, are you around? I can see him at this point. Oh, yes, Friedrich is around. We just need to unmute you. Yeah. So Friedrich, I have a question. You're a surgeon, a biomechanist, a scientist, and you know more about this than almost anybody. Now, you have a patient who has an 8 centimeter central abdominal wall defect. It's an incisional hernia from previous surgery. So it's an 8 centimeter defect. Now, based on all this tremendous amount of knowledge that you have about the abdominal wall, the dynamics of instability and stress, what is going to be your approach to that patient? Mind you, I'm not asking you about a multiply recurrent 20 centimeter defect. I'm asking you about a straightforward 8 centimeter defect, which is not really small, but neither is it very big.
And how long is the incision line? Is it all the 8 centimeters or is the incision line longer?
I'm talking about the width. So typically, if you take a 6 to 7 inch, say around 12 to 15 centimeters length, that
So
would
it's
be
8 times 12 centimeter defect.
Yeah.
I would probably do a small release on top. You know, I say it's para-umbilical, so it will reach 6 centimeters above the umbilicus. So I do a small release on top to have a good size, like a 20 times 20 centimeter mesh in it. And then I would probably use around 40 or 50 stitches to get it fixed in all areas.
And what operation is this?
I don't know how you call it. An operation according to the grip concept. If you want me to calculate it, I could calculate it to make it durable.
No, what I mean to say is, are you going to do a laparoscopic IPOM, or are you talking about an open retromuscular Reeves-Topa kind of operation, or an onlay?
You can do a transhernial myelus approach.
Okay.
And then you would have a very small incision, like you have a young woman with this size of defect, then you can have a small incision. You can have some correction of the hernia distension for her to look cosmetically good, and you would still have a durable repair.
So if you look at the bulk of the surgical world, they don't do mylos or e-mylos. So they would do either an open onlay or a laparoscopic IPOM or an open minimally invasive or minimally invasive retromuscular approach. So let's just take an IPOM. So if you look at our hypothetical patient of 8 centimeter width hernia, which is say around 15 centimeters long, what kind of mesh would we need in IPOM, and would IPOM be an advisable procedure for you? Or for
I would not do an IPOM for this case. I think the hernia defect is too large for an IPOM. If you want to wait for a second, I calculate it out. You said it's 8 times 15, right?
That's right. So that's 120 centimeters if you multiply it.
Yep. So it would, we need a 75, and we get with an IPOM, you would need at least a 25 times 20. And I personally think it will not be able to fix this symmetrically, and I would not do it as an IPOM. I would probably do, if I could do a myelus or an e-myelus approach, I could probably do an open sublay repair.
And here you're talking about an IPOM without defect closure?
No, I would always attempt a defect closure on this.
Fine, fair enough. Brian, please. I see Brian. but I think his picture is frozen. All right, till we get Brian, let's take some views about both the talks from our panelists. Let's start with you, Hugh.
I
What
thought
are your comments?
it was an incredible talk, actually, Friedrich. You sort of answered most of the mysteries of hernia repair and hernia failure. It's always mystified me going in laparoscopically and seeing these meshes that have slid away from the defect. And I could never understand how that could possibly happen. And even looking in laparoscopically and seeing retromuscular meshes that had just moved away from the defect, and it's incredible. And I've always said that as I get older, my meshes get bigger and my fixation gets more permanent. And I think you've explained why. I certainly use ProGrip for everything, and I think it's interesting that you basically showed that that's a superior mesh as far as you know, grip goes. And I think it's fascinating that we can look at the CT scans and figure out the flexibility of the abdominal wall, but also look at a CT scan from a failed IPOM and actually figure out why one side failed and the other hasn't. So thank you very much for that. I think we could all integrate that science much better into our practice to choose appropriate mesh size, mesh type, and fixation.
All right, thank you. So let me ask Meenakshi Sharma, who is a surgeon in Gurgaon, Delhi. Meenakshi, based on what we've heard and seen this evening, how has it impacted your views about the subject of incisional hernia repair? What is your overall take on this?
Thank you very much, Dr. Kallinowski and Dr. Jacobs, for your excellent talks. These are new concepts, and as Brian said, we definitely need to examine the tissues and the points which you brought up, Dr. Kallinowski, about the kind of tissue we are dealing with here is really very pertinent, and unfortunately, most of us don't even think about it. And your point of the mesh suddenly slipping away and the recurrences happening even in the best of circumstances is what puts my mind to think more and to actually try to work out. So actually we need to, you know, hear you more, and we need to understand this concept even more. But definitely the one takeaway point here is that we are not thinking enough. We need to, you know, understand more about this concept of how the, for example, what you said about the regionally unstable abdominal wall, and how we need to correct this weakness is like, you know, something very pertinent, because very often in the incisional hernia repair, even if when we are repairing laparoscopically, we'll have an adjacent area which appears weak, but we kind of, you know, end up fixing the edge of the mesh sometimes over there. So what do you do if, you know, for example, in the CT, you may not have found that to be a weaker area, but when you are actually repairing the hernia, you think that area is not particularly stronger, and you have put in the mesh and you are trying to fix the mesh. What do you do at that time to reinforce?
Yes, there are two ways at the moment. If I still have an abdominal wall area left, like when I'm directly at the edge of the ribs or at the edge of the pelvic rim, then it's hard. I could do bone anchors there, but they hurt. So at the moment, I do a triple row of staplers to sort of get a very good grip, to have the maximum grip at this area. You can calculate a regional grip. Once you have a global value, you can calculate a regional grip. In this area, you should have a very good grip, but we have no good study now. If we look at the talk of Rodney Jacobs, you know, he showed all those very good retrospective reviews, you know, all those amount of patients. And when you look at the studies, I think in about 1/3, there is not even a defect size given, you know. The defect size indicates what is the instability I need to address. So I think we are now talking about unstable abdominal wall, but we should also take into account that people do very complex studies and they do not record the defect size or the mesh size in the first place. You know, both things are important, I think. So I thank Dr. Jacobs for his very good talk about all those things.
Thank you. Brian, are you there?
Yes.
Okay, great. So comments about the overall discussion, number one. Number two is, because you do a fair number of IPOMs and you do support it as a good procedure in specific situations or on a broader perspective, what is your take on fixation? How much depth do we really need to create an effective grip for an intraperitoneal mesh? How many of these fixation anchors do we need? And are sutures and these anchors, a combination of it is better or one or the other? What is your overall experience over the years?
Appreciate the question. So a little background for the audience, because again, we have to compare apples to apples. I'm in practice for about 18 years, and my IPOM is not the standard way people do IPOMs. So I deperitonealize the posterior fascia always. So it's basically my mesh is going into the TAPP space. So the fibers of the mesh are going to be directly up against the posterior fascia. The second is I close all my defects. And the third is I will only use an IPOM up to about a 5 centimeter defect. I will go to 8 if in the category of Friedrich that there's a really lax abdominal wall where the defect will close. So there's never a bare area. I've always believed in that the mesh will not recur or will minimally recur if it has max surface area of tissue ingrowth. So he calls it grip, I call it tissue ingrowth strength. And we did some studies with mesh back in 2007, 2005, looking at the tissue ingrowth strength. So that's the reason I stick with the IPOM the way I do it. The second is the mesh choice. In the States, we primarily have 2 companies that we are allowed to choose from. There used to be 3. The 2 that we have are Medtronic's and we have Bard. I typically have been choosing Medtronic's mesh. The PCOX, which is not the Symbotex, it's the recent version. This is a 3-dimensional weave polyester product with a collagen-based anti-adhesive barrier that was invented by Michel Thurin. He's a scientist, he's not a surgeon. He started a company called Soferdim, and it was purchased. And so the mesh itself is very important. And for me, with all the work that was done with it, I believe in the science of it. So that's just a little background on why I choose IPOM for up to those size defects. So it's not, again, it's got to be apples to apples. So if you do your IPOMs exactly that way, then we're talking. And if you vary your technique, then what I'm saying doesn't apply to you. So the question is, how many points of fixation? If you do it that way and you close all the defects, you do not need transfascial sutures. I do believe in fixation at least 1 centimeter apart, 1 centimeter from the edge, the way we used to teach back in the 70s. I'm kidding, back in the, I guess, the late 90s, early 2000s. And then I don't like any bare area, so I'll put a row of fixation, which is tacks, in the center of the mesh. When I do it this way, the patients that I love doing this on are the ones that have a little bit of adipose tissue on the inside of their belly, so there's always a healthy omentum in case there's an issue. And the really, really skinny people, I will probably still do a retrorectus repair and get the mesh out of the belly. Does that answer your question, Ram?
You missed the issue about the depth of penetration that is optimal. So would it be 5 millimeters, 7 millimeters, and which one, in your opinion, regardless of your commercial interests, which one would give the best overall bang for the buck, feel of it, the effectivity of the penetrating fixation, as well as the depth-wise, the physics-wise?
You're talking about the different fixation devices?
That's right.
Give me a multiple choice test, so I can, then I'll answer it that way.
Capture, secure strap, endo anchor, whatever else there are. I use these very seldom, but yes.
Sure. The reason I asked that is there's so many on the market, and they go by so many different names. To be honest with you, all these devices are tested enough that if they're deployed correctly, they should do their job, and they should do their job well. So I don't think it's fair to say that one is better or deeper than the other. To be honest with you, at my hospital, we're dinosaurs here. We still have the ProTac. We have a titanium ProTac. We're probably one of the only hospitals, and there's about 15 minimally invasive surgeons doing IPOM repairs at this hospital, all using ProTac 2 or 3 times a day. So, you know, that's a lot of patients in the New York area walking around with metallic tacks in their belly still. And if there was an honest to God problem with it, you know, over 20 years, at least at this hospital, we would know it and we would have stopped. So within our own hospital, our own data, we don't see some of the issues that studies have quoted. So we use ProTac here.
Okay. Cool. We have a very experienced senior Indian surgeon with us, Dr. Sudhir Kalhan. He's the chairman of the Institute of Minimal Access Surgery in Sir Gangaram Hospital, New Delhi. So it's one of the ivory towers in North India. Sudhir, can you hear me? Are you here?
Yes, yes,
Right.
yes.
So Sudhir, my question to you is, number one, your views on the discussions of the evening, and number two is, as an IPOM protagonist or as a surgeon who has used IPOM extensively over his career, do you think the problems with IPOM are hyperinflated and they have more to do with surgical technical errors than with the actual engineering failure?
See, Ramana, first of all, I must congratulate you for arranging 2 very nice, fascinating talks. And I think what we've all understood in the last 2 decades is that probably what we were doing in an IPOM by just doing a bridging closure with a large mesh was the wrong thing. And I think all of us had patients who were not very happy with the outcomes. The bulges were still there. There were recurrences from the margins. There were complications in terms of surgical site infections. There were large seromas. So all of us actually were forced to think. And ultimately, I think there is no rocket science in this, that a good midline repair and a reconstruction is the need of the hour. And also a lesson which we have learned in the last 2 decades is that please spend a lot of time in evaluating a patient who comes with hernia, because the size of the hernia is very important. And as rightly said, the which portion of the abdominal wall is unstable, and what is the tissue which we are going to approximate, what is there. So the understanding the biophysics, the biomechanics, choosing the mesh well, choosing the size of the mesh well, fixing the mesh well, the post-operative care, I think they go a long way in the outcome of the hernia repair. And I have no shame in accepting that in the last 2 decades we were a little more complacent, and we were just doing a bridging repair with a IPOM with a large mesh. And I think we realized our mistakes, and we are on our path to the correcting our path, and ultimately realizing now, ever since you started doing a abdominal wall reconstruction in the last 3 or 4 years, that the results and the outcomes are much better.
Thank you for that. Pinky Thapar is head of the Department of Surgery in a very posh Jupiter Hospital in Mumbai. So Pinky, I believe you were an IPOM surgeon and then suddenly you've turned chicken. What's happening?
Basically, I'm still an IPOM surgeon occasionally. I've seen a couple of cases, complications, a few my own and few of some good surgeons who have done the surgeries. So after seeing such major complications of bowel obstruction, fistulation, recurrences, especially in
I can't see your
moderators.
video. You have to start your video. Yeah, there you go.
I'm seen now, yeah.
Yeah.
So basically, I'm still a IPOM fan, but I have my reservations for choosing it for all patients. So I would agree with Dr. Friedrich that we have to understand the physics of the patient and choose the patient's, the hernia which is best suited for that patient, rather than, saying I can do only one type of a hernia surgery. So we should be knowing different techniques and choose the best for that patient. So earlier we used to do IPOM plus for patients who have 8 centimeter defects or 7 centimeter defects. So I have reservations for that now, since I have seen a couple of complications. In fact, a mortality too, operated by a good surgeon, but came back with bad adhesions, recurrences, fistulation. So after seeing these bowel complications and dense adhesions, I have my reservations for every patient, IPOM. It should be done for select cases. That is what I would like to say. And today's talk, I think it was excellent. Dr. Friedrich pointed out the important intricacies of hernia repair, which we all should be aware of patients' mechanism, abdominal wall mechanisms. And we should not have a fixed idea of doing only one type of surgery. So we all should keep on learning and give the best result for the patient.
All right, thank you. So I'll let Brian have the last word and then we'll close.
I don't deserve the last word. Look, this is an interesting era that we live in. To be honest with you, at least in the States, my opinion is that the rise of the robotic techniques came with an anti-IPOM marketing campaign. And I think that if you add to that the fact that the Europeans really never loved the IPOM, I'll grant that. I think that's why we're seeing so many more attempts to get the mesh out of the belly today. For those of us who trained and really do have good outcomes with the IPOM, and we are very quickly becoming outnumbered with the people who want to get the mesh out of the belly. When I hear of the cases of high recurrences and fistulas, and as Pinky just said, the rare mortality, you got to go back and examine those cases specifically. Yeah. There has to be something about the technique and the mesh choice and the patient choice that could be dissected out to blame for those complications. I just don't see those complications in my practice. I don't maybe have those kind of patients, but to be fair and just and open, I don't think we should be bashing a technique just as a sign of the times. I think we need to look at each case specifically, and we all agree on that.
I'd like to... Brian, 5 centimeters is your upper limit. So that is really not the challenge for most situations, regardless of the technique you adopt. If you follow sound surgical principles, you're a decent surgeon, you shouldn't really be having too many recurrences in small incisionals or ventrals under 5 centimeters. What happens to the ones which are bigger? How does the game change there, in your opinion?
Well, again, if you look at Koechling's study at the size of the defects with the recurrences of physiomesh, they weren't all giant hernias. Frederick could tell me that if he recalls the exact size of that defect, but if you bridge anything with a lightweight mesh, it's going to eventuate over time, as he mentioned. Even in good techniques, but certainly in bad techniques and with bad fixation, that's going to happen. So the only reason why I choose 5 centimeters, and it's not a hardcore rule, I may go to 6 in some patients or 7 in some patients, and I may not do it in 4. It's all about my ability to reconstruct an abdominal wall and then reinforce it with mesh. If I can do that well with an IPOM, I'll do it. And if I can't, I'm going to go retrorectus, and if I can't, I'm going to go TAR. It's really that simple.
I
agree, concur.
I was going to back up what Brian was saying, in that it's the quality of the surgery that's important. It's not the platform on which it's carried out. And so great IPOM is a great operation. A bad IPOM is a bad operation, just the same as a bad TAR is a bad TAR and a good TAR is a good TAR. And if you choose who you operate on and manage the patient and the hernia as a whole entity, not just the fact that this is the operation I do and this is the operation everyone gets, then you get a better result. And look, like Brian, I don't get to do many IPOMs these days because it's just not the practice I see. But when I do them, I close the defect, I take all the peritoneum and fat off and tap to the muscle, and I close the defect. And I probably only do an IPOM up to 5 to 6 centimetres too. And if it's above that or the abdominal wall's not compliant, then they get a different operation.
Okay.
Patients are happy if they get their hernia fixed. It doesn't matter whether you do it with a straight sticks, a robot, chopsticks, or a big cut. It's fixing the hernia that's the important thing.
That's right. And as Pinky said, you have to, a competent hernia surgeon should be able to do IPOM, do a TAR, do a retrorectus, do whatever. There's no hernia operation that fits all things. When I went to Washington AWR meeting in 2010, it was all about anterior component release. And then we went back in 2011 and it was all about the complications of anterior component release. And Mike Rosen said, I'm cautious about supporting any technique because I know everyone will do it on everything. And I think you guys have seen that with ETAP, haven't you, in India, Ram?
Yes. Okay. So concluding remarks, Friedrich, advice for the general surgeon interested in doing a safe incisional hernia surgery.
We started investigating from 5 centimeter on because the hernia made registry showed that below or up to 5 centimeters, at the most up to 7 centimeters, IPOM is a superior technique, you know, in terms of having less long-term complications and less recurrences. So we started our work on this base and investigated incisions above 5 centimeters. And I think the really hard ones are the ones which are disabling for our patients. And if we find a way to do them without recurrences, we give these patients the life back. And I think below, smaller hernias should be repaired with the IPOM technique, as told before by Dr. Jacob. So wonderful. This would be my conclusion.
Okay, great. Thank you very much. And thank you to all the panelists and Rod, Brian. Had a wonderful Saturday evening, and I hope you guys have a great weekend. So let's meet again sometime soon in another Smart Talk. Bye.
Great, thank you.
Thank you.
Thanks,
Good night.
man.
Good night, Hugh.
Yeah, mate. Happy Father's Day.
Oh, thank you.